Hello, friends. This is a little offbeat topic that I'll be just covering on the mnemonics in intensive care. Whatever mnemonics I have collated is uh, something that has been useful for our day-to-day practice. Just a part one. So, thank all my trainees who contributed to some of these mnemonics, in particular my Lakshman, who in fact presented some of the mnemonics. So, we just collated few of the mnemonics which may be useful for day-to-day practice of intensive care. So it's a very random sort of an approach to this topic. So there is no sort of a systematic way that I have gone through. So just picked up the random mnemonics, which may be of some value in day-to-day practice. And some of the mnemonics are very intuitive and fairly common and known to most of the intensivists. So I'll just take you through the common mnemonics which are useful from practical point of view. I won't dwell into detail of this fast tag. So every listener here would know the fast tag that we adopt in ICU. For any new trainee, these are all the quality indicators. So fast tag, each and every entity of this fast tag are a quality indicator, and every patient in intensive care, some of these aspects have to be incorporated. So just for the someone who are very new to this, just F stands for early feeding within 48 hours. A is every ICU patient should be free of pain and should have adequate analgesia and should be adequately sedated in someone, especially who are on ventilator. Thromboprophylaxis for all patients in ICU who are at moderate to high risk of venous thromboembolism. And this is H is a very simple intervention which seldom I see some of the ICUs. It may not be reinforced mandatorily. That head end elevation is a very important aspect which has a multimodal benefits. Stress ulcer prophylaxis, especially in patients who are at a risk for upper GI bleed, and glycemic control. So blood sugar to be maintained less than 180. And various studies have shown that it reduces mortality by 29.3%. And so all these are sort of quality indicators. There's no debate or dispute on any of these things. So the extension of this, the reason I'm talking about FASTag, which I'm sure most of you know, is each unit may be using certain additional aspects to this FASTag. So in the My ICU, we use extension of this FASTag called PSMN. P stands for physio and early mobilization, which incorporates both. S is to look at the stools and make sure there is bowel care and bowel opening that is happening, because we did publish a study on how constipated patients have a detrimental outcome, especially in sepsis or septic shock and severely ill patients. So we have our own studies. So it is important to pay attention, like urine output and having a bowel output or passing stools is a reflection of the bowel function, and not passing stools is a reflection of bowel dysfunction. So we put emphasis in my unit on stools and music, and we believe because there is a good science that shows that the noise levels in ICU has a tremendous bearing on delirium component, and replacing that noise with either earplugs or music. And there are multiple studies which have shown that music has a favorable effect on improving their outcomes. So this is what I utilize in ICU. So there's no robust sort of evidence, but all these are backed by evidence. So early mobilization, stool output or bowel care, and music, and negative balance. So PSMN is for all doctors, preventive and social medicine. So I use FastTech PSMN is written every day in our charts. So negative balance, try to attain net cumulative balance of 0 by day 3, and day 7 try to attain negative balance. So this is what we use in our ICU. So in 2023, just around 2 weeks back, there was a article that came out in one of the journal looking at this extension of fast touch in bed sleep. So this is also a mnemonic or an acronym for various other dimensions that have been incorporated. So I'll just take you through this. You can try to customize it to your unit as to what are relevant to this. So, I first anyway we have spoken. So S stands for skin and eye care. So important. So which we do it fairly routinely in our ICU. It is more emphasized. I stands for interdisciplinary care, and this I believe goes without saying that ICU is a team science. We are interacting with other multiple core specialties, and it involves multiple teams, and having a good coordination has a bearing on improving the outcome. N stands for new score. This is early warning score, basically to try to identify certain signals which are telling you that patient is going to become sick. B stands for bowel care, which I said we have incorporated with PSMN. S is for stools. So here also the extension of this, they have paid attention on bowel care. E is again environment. And I think, as I said, intuitively, like we have been practicing this maybe more than 10 years in our ICU, that we replace the noise with earplugs and iPads and music. So they have put an emphasis on environment. So making sure that the environment is conducive, lessening the noise level, and having a daylight alienation, so on and so forth. So putting in a favorable environment for a patient has a tremendous bearing on improving their outcomes. So all these are there in the extension, which is just published in a recent journal, which came around 2 weeks back. D is for de-escalation, and this is incorporated as part of your antibiotic stewardship. That any patient who is an antibiotic, it is important that by day 3, evaluation is done to see that antibiotics are de-escalated to the focused sort of a antibiotic, and not to keep continuing multiple or indiscriminate usage of antibiotics. And P is psychosocial support. This is some area where possibly we can put more emphasis. So in our ICU, we have a social worker who coordinates sort of a ongoing communication, who acts as a coordinate between the family and our medical teams to address certain psychosocial aspects of the family needs that may be brought into our attention. So this is one area possibly we can pay more attention. Limitation of the care, end of life policy is a quality indicator. We have these protocols in our ICUs, and this has been included. So this comes as fast as. So it is basically to recall, again, putting emphasis on certain quality indicators putting in place. So limiting the care and not inappropriately continuing certain advanced life support measures in someone where there is utility of some life support measures with a non-reversible underlying condition. E is possibly just to complete the please. I think E has been added. It's again to see, evaluate the ongoing drugs and see the unnecessary drugs that could be stopped and look at the drug interactions. So this possibly I wouldn't pay too much attention. A is admission and discharge transfer. So this is there as a quality indicator. It's a structure indicator where every ICU should have admission and discharge criteria. So A is admission and transfer sort of a policy that you have. And S stands for, I think this is again to complete the please. I think pretty much please is something which I think may not be too much pertinent. Like shock, suspecting shock, workup and treatment anyway, it goes without saying. So they'll just put it to complete the fill in the blanks of please, I suppose. E is early mobilization. Like PSMN is the easiest because I have incorporated early mobilization, I've incorporated bowel care, then I've incorporated the environment, and N is for negative balance. I still believe that maybe the more robust sort of a mnemonic to keep in mind. But as I said, each individual can customize to their liking. So faster in bed, please, is something that you can remember. But I still believe some of these entities are just put in place to complete this sort of a uh, statement that they have made, or a mnemonic that they have made. So that's about the fast test. So this is very useful one, which every nurse in my ICU knows about 7 normals, and every ICU nurse who undergoes the induction program are trained into 7 normals. Any neurological patients, traumatic brain injury, stroke patients, or obtunded patients due to neurological insult, 7 normals are something mandatorily every trainee of ours and nurse knows about it, where we talk about maintaining, taking steps to prevent the secondary damage to the brain. So like normoxia, normocapnia, normovolemia, normal blood pressure, normal temperature, normal glycemia. When I say normal glycemia, it incorporates normal electrolytes, so on and so forth. And osmolality is a reflection of sodium and urea level. So basically, normoglycemia and normosmolality encompasses all the electrolytes. So this is something which we pay a lot of attention. These are simple things, making sure that any patients with a insult to the brain are not hypoxemic, there is no hypercapnia, they are not hypovolemic, and they are not hypotensive, and they do not have fever. Making sure they do not have hypoglycemia or hyperglycemia, and making sure they have normal sodium, potassium, chloride, magnesium, calcium, phosphorus, and so on and so forth. So this is extremely important, very simple, but these are so valuable in protecting the brain integrity, especially to prevent secondary insult. Each and every aspect of this normal has a tremendous impact on improving the outcome. So this is another sort of a mnemonic you can remember. So this is another mnemonic for any obtunded patients. I've covered this in a previous video. Any obtunded patients in ICU, I ask my trainees what are the differentials. In fact, we write on our chart as to whether all these are ruled out. So anyone who comes with altered sensorium and you want to break your head as to what are the differential diagnoses, think about whether there is an alcohol on board or arrhythmia. AEIOU-TIPS. So AEIOU are vowels and tipsy, you can remember as patient getting tipsy. E stands for epilepsy or electrolyte disturbance. I stands for you have to rule out infections. O stands for overdose, hypoxemia. U stands for uremia, metabolic. T stands for toxin, trauma. And I is for hypoglycemia. And P is for psychosis or psychological causes of obtundation. S is stroke. And E is endocrine like hypothyroidism, hyperthyroidism, hypoparathyroidism, so on and so forth. So a very simple mnemonic, and it is a very useful mnemonic at least to make sure that you tick off each and every cause as a possible reason for someone's obtundation or altered sensorium. Very useful tip, and I have heard of this mnemonic when I was in Australia when we had this Viva sections or OSCE sections. We used to recall all the differentials based on this AEIOU tipsy. So very useful mnemonic. Keep this picture in your mind and use it in your clinical practice. It is very valuable because we have picked up so many patients who come with obtundation where we have looked into endocrine cause or we have looked into sort of a toxin or we have looked into infective cause, so on and so forth. So recently I did a talk on one of the encephalopathies. So the drugs causing seizures, the mnemonic is OTIS-SCAMELL. So very useful tip. O stands for opioid, T is for theophylline, tricyclic antidepressants, I is INH insulin, S is salicylate, C stands for cocaine, cyanide or carbon monoxide, A is amphetamines, anticholinergics, M is metaldehyde, P stands for carbapenem, imipenem, meropenem. Any of these have seizure threshold or levofloxacin. B is barbiturate, E is ethanol, and L is lead or lithium. So again, if you have to recall any drugs causing seizures, if you have to rule out if someone has come with seizure, you have done MRI, there is no structural abnormality, and you have done EEG, does not give you a focal area, then obviously you have to rule out if any of the drugs the patient is taking. Just look into it. It's a very easy mnemonic, Otis-Campbell. It just gets you to tick off because we have seen in ICU patient having seizures due to carbapenems or even due to levofloxacin, so on and so forth. So it is important just you have this in mind to rule out the drug causing seizures. So this I'm sure every listener here would know, but for all the newbies who are entering intensive care, cholinergic symptoms due to OP, we have SLUDGE, so increased salivation, lacrimation, urinary incontinence, diarrhea, GI cramps, or MSCs. I've just shown pictorially. So this is something which I'm sure most listeners, but please keep this in mind because in exams in OSCE we do ask in sort of IDCCM or other exams. It's good to know these typical markers. There's another mnemonic called dumbbells, where diarrhea, urination. So you can use either of them because this sludge does not have bradycardia. So if you see dumbbells, it has bradycardia. And bronchospasm also is there, which is not there in sludge. So these are some of the nicotinic effects which I had covered in another video in OP poisoning. Just put pictorially nicotinic, they can have mydriasis, hypertension episodes, tachycardia, cramps, weakness, or muscle fasciculation, and central effects of OP or anxiety, confusion, or seizure. So dumbbell and sludge is what you can remember for symptoms of OP poisoning. So we'll just move up little out of the context of ICU. Depression is another important sort of a situation we see. So the mnemonic for that is SIG-ECAPS. Again, easy to remember. S is lack of sleep. I is lack of interest. G is having guilt. E is lack of energy or increased fatigue. Or C stands for lack of concentration. A is loss of appetite. E is psychomotor agitation, and S is suicidal. So I know this may not be core ICU, but we do see very often patients coming with overdose or suicidal attempts. So as an intensivist, as a physician, you are required to elicit if there are features of depression. So it is very easy to run through this questionnaire, whether they have lack of sleep or lack of interest or all these components, lack of or suicidal ideation, agitation, or lack of concentration, so on and so forth. So SIG-ECAPS is a mnemonic you can keep in mind to rule out. Even it may be very valuable when you're dealing with any other patients coming with a lot of psychosomatic symptoms and you want to rule out depression. So the most striking being patient in our OPD, we used to see a lot of depression patients and we used to find this questionnaire very useful. The simple questions we used to ask us whether their appetite is decreased, whether their sleep is decreased, or whether they are losing interest in their routine day-to-day activities. That will really get you to clinch the diagnosis of underlying endogenous depression in many of these patients. So SIG-ECAPS is the mnemonic for depression. So very often in ICU, we have diagnosed multiple myeloma or paraproteinemia multiple times. And the simplistic indicator to look at is the CRAP symptoms. So C stands for hypercalcemia or is renal. Very often we have diagnosed multiple myeloma in ICU where they come with sepsis and we would have seen they may have had hypercalcemia, acute kidney injury, and they would have an anemia and some bony lesions. So they'll have a lytic lesions in the bone. So CRAP symptoms is easy to remember are the ones we look for. And many a times you would think that it is the chronic kidney disease which has caused anemia. But many a times you would see that kidneys has not shrunken and it is of an acute onset. So this is something useful to remember CRAP symptoms. So hypercalcemia, renal dysfunction, anemia, and lytic lesion. B is bony lesion. So this is also useful for nurses, pressure injury prevention. The mnemonic we use is skin care. S is for surface support, which means if someone is at a high risk for pressure sore, we would obviously put on alphabet or we have to put on specialized nimbus and so on and so forth. And keep turning the patient. So SK stands for keep, obviously positions have to keep changing to reduce the effect of pressure on one area and they have to be managed for any urinary incontinence with diapers or catheter and so on and so forth. And adequate nutrition. Focus on N stands for nutritional support. C is Cavalon spray, which has to be used to keep the area dry and facilitate healing. And A stands for assessment of risk. And R is restriction of head end elevation. So basically, taking precautions for lifting the patients and head end elevation and E is elevation of tail. So it is more useful for nurses. Mainly in ICU, we see very often long-term patients developing pressure sore. So skin care is something that you can keep in mind. Make sure that position change is happening, adequate nutrition support is being given, some sort of a spray is being applied, and elevation of heel is such a simple thing that one can do to prevent sores at those sides, so on and so forth. So this is skin care and goes well with sort of a clinical context of preventing the pressure sore. So this is the mnemonic for preventing pressure sore. So this is useful for intensivist delirium bundle. The mnemonic is ABCDEF. So delirium is a very common sort of a condition we see in ICU. A is assessment, prevention, and management of pain. So pain is an important sort of a trigger for delirium. And someone who is unventilated, making sure that there is a spontaneous awakening and spontaneous SBT. And this is a quality indicator to put every ventilated patients on some sort of a weaning mode, and that has shown to reduce the risk of delirium. So spontaneous awakening trial and spontaneous breathing trial is an important component to minimize the delirium. And choice of analgesia and sedation. Obviously, we know more usage of benzodiazepines increases the risk for delirium. So de-emphasizing on the usage of benzodiazepines and looking at alternative sort of sedation or analgesics goes a long way in mitigating the delirium. And D is delirium assessment using various sort of scores that are available. And E is early mobilization. And F is engagement of family and involving them in minimizing the risk of delirium. So very easy mnemonic to remember A, B, C, D, E, F. So you can remember these pictures to recall because in exams delirium is a common question that will be asked. So you can write this mnemonic, how the prevent the broad dimensions which can be utilized to minimize the risk of delirium. So this is the so brain MD is the mnemonic that we use for SLE. I know there are multiple criteria, but this is something which we have used within our ICU in many patients where you do not know what the diagnosis is. So brain S stands for serositis, O stands for oral ulcer, A is arthritis, photosensitivity, and B stands for any blood problems like leukopenia, thrombocytopenia, renal, ANA, immunologic, or neurological, and malar and discoid rash. So there is a score for each of this. So this is a very simple tool which has been helpful in diagnosing SLE many a times in our ICU patients and very easy mnemonic to remember. So malar and discoid rash, one of them have to be present for diagnosing the SLE. So brain MD is again a useful mnemonic many a times where we have picked up the diagnosis. So someone, in fact, I would say in ICU, at least in a month, we would at least identify one with some sort of an SLE, at least once in 2 months, where we have picked up based on these criteria, where they have unexplained serositis, and where we do an ANA comes positive, and they may have some sort of a bicytopenia, leukopenia, or thrombocytopenia with renal dysfunction. These are the typical sort of a spectrum patient comes with, and we do an ANA comes positive, and further investigations reveal that the diagnosis would be SLE in this patient. So they use the mnemonic. Many a times it's hard to find out malar rash or discoid rash. In ICU, when they come with serositis and leukopenia, bicytopenia, renal dysfunction, and sometimes neurological dysfunction. But very seldom have I seen someone coming with malar rash, discoid rash, or even historically, if we ask for arthritis, many a times it will be absent. But think of doing ANA because ANA is one of the important criteria which can clinch the diagnosis of SLE, and you can apply this. Serositis is very common. We see patients coming with some pleural effusion, some ascites, with renal dysfunction, with leukopenia. This is the typical spectrum they come and we picked up SLE in this patient. So this is the other useful mnemonic which we can say that possibly, I have sort of devised this mnemonic, but it is there. Any patient with ischemic heart disease or acute coronary syndrome, we use this mnemonic AEIOU-BCDNS. So any diabetic who has ischemic heart disease, anyone coming with, think of these ABCDNS. These are the drugs the patient should be on in some format. A into 3. So there are 3 A's. So 3 A's are aspirin, AC inhibitors, and aldactone. So make sure that any cardiac patient with an LV dysfunction, so they need to be an aspirin and AC inhibitors provided the renal function is normal. And I put aldactone, which is the trade name, spironolactone. This is for especially in patients with LV dysfunction to prevent LV remodeling. They need to be. So I'm not telling that you need to put all ABCDNS, but think of these drugs that needs to be thought of in any patient with an underlying cardiac condition based on whether it's cardiac condition with a preserved ejection fraction or is it a cardiac condition with reduced ejection fraction. If it is with a reduced ejection fraction, you have to think of AC inhibitors and you may have to think of spironolactone. B stands for beta blockers. Obviously, you will have to determine whether your patient has LV dysfunction. If there is LV dysfunction, then you would think of carvedilol. Or if there is normal LV, you would think of some form of beta blockers in this patient. C, I know I put as Clexane, which is a trade name. It's enoxaparin anticoagulation. If someone has an ACS, you would think of anticoagulation with low molecular weight heparin. D is diuretic. So any patients with ACS with failure symptoms, you would think of diuretics. N is nitrates, especially someone where you need to optimize preload, you have to think of nitrates. And S is obviously statin. So very simple, but we use this all the time in any patients with a cardiac problem. Think of AEIOU-BCDNS. And pretty much, even if you look at a cardiologist, he would be putting any of combination of these drugs based on the type of cardiac conditions they would have. So very useful mnemonic. And I tell all my trainees to think of ABC. Any cardiac patient, we make sure that any of these key drugs is not missed out from the armamentarium. So this is another mnemonic which I should say possibly I have devised this for all these oncology patients who come with shortness of breath, and we have even published this in one of the article which I'll show you. So, see, oncology patients is a very complex group of patients where the differential diagnosis runs in a myriad way. So, we need to have some clarity, and oncology patients pretty much come to ICU with hypertension and shortness of breath. And you need to have some clarity how do you approach the differential diagnosis. Oncology patients are at a high risk for venous thromboembolism. So with CLE is the mnemonic that I have devised. V is venothrombotic embolic disease, so or a venous thromboembolism. So VT is a very high risk. All oncology patients are at a high risk for venous thromboembolism. So VTE should be thought of. TE of some nature has to be thought of. And I is infection. Yes, oncology patients are immunosuppressed and they are not on chemotherapy drugs. The risk of infection is very high. You need to rule out infection. T is very important. All oncology patients, when they come with short-term stress, the diagnosis from intensivist point of view is not only infection. It could be even the progression of the disease. It can be tumor progression of some nature with metastasis to the lung. So even that may be causing shortness of breath. Tumor progression anywhere in the body, like if it is a big tumor progression in the abdomen, that may be putting some distress to the lungs, so on and so forth. So tumor progression has to be thought of in any oncology patients who is worsening. And this is C is what I put as checkpoint inhibitor pneumonitis or drug-induced pneumonitis. Why I put checkpoint is oncology, there are a lot of newer drugs that are used, and checkpoint inhibitors are something that they use very commonly, and it is known to cause pneumonitis, or it can be radiation pneumonitis or drug-induced. You remember as drug-induced, C stands for, we had to put that to make it simple, that vitamin C with C, but you can put as a drug-induced pneumonitis. Basically, it can be any drugs that many oncology drugs can cause pneumonitis, or some of the oncology patients may be on radiotherapy, which can cause radiation pneumonitis. So it is non-infective. There may be an ongoing perpetuated inflammation of the lung that may be happening. With C, LE, LE is, you can remember, and with C, leukocytosis, or however you would remember. L is lymphangitis. Don't discount the fact that oncology patients can have lymphangitis. There are certain cancers like adenocarcinomas or renal cell carcinomas which have a high propensity to cause lymphangitis carcinomas or breast CA for that matter. And this can lead to shortness of breath. And very often it's very hard to make a diagnosis of lymphangitis in an early stage. So L stands for lymphangitis. Think of this as a differential. Very important. We have missed in many cases the diagnosis of lymphangitis, and we would be treating as infection or so on and so forth. Infection, or many a times any onco patients come with SOB, we think of infection, but you have to rule out all these differentials. Lymphangitis is an important one, and please go read up. There are certain cancers which have a very high predilection to cause lymphangitis, like CA stomach or RCC has the highest risk of causing lymphangitis. E, very important, you have to rule out edema. It can be due to cardiac failure leading to pulmonary edema, or it can be pulmonary hemorrhage because many of the oncology patients may have low platelets and they may have coagulopathy because of various reasons. So edema and hemorrhage. So VITH-CLE is the mnemonic that I have only formatted. I think it is important that we think of this in any onco patient who come with shortness of breath or worsening conditions. Think of, and we do have to rule out this. And these are the publications we made. So this is the cytokine release syndrome due to checkpoint inhibitor. The reason I had to show this publication is this is very common because I have to confess, intensivist knowledge in onco drug is very poor, and we all have to get educated and try to have more awareness on the type of drugs they use, because most of these drugs have a very myriad and a vivid sort of a side effects, and we need to be aware of this. So this was a publication we made on cytokine release that happened due to the usage of checkpoint inhibitors like nivolumab and ipilimumab. And this is the publication that we made on differentials of lung patients who come with lung metastasis. And this is the picture which I showed you, which we have published in this journal as a letter to editor, where we have put up this mnemonic as with CLE. So those are some of the mnemonics. Hopefully they will be useful, and all these mnemonics will have practical application and they're not theoretical. So hopefully they will be valuable to your day-to-day practice. Maybe I collate around 14 to 15 mnemonics I have said. Maybe part two, if I get better mnemonics for certain diseases, Like I wanted to include biceps score, Ranson's mnemonic, and so on and so forth, which I may possibly do it in the second part. So that's about it. Thank you one and all. So I request you all to submit your valuable work to our journal, Journal of Acute Care, which comes out every 3 months. And visit my website www.drsangappa.com to read it. Thank you one and all.